EMS.
Okay.
You know, these people might be coming in via emergency medical services, and they can give you a little bit of history if they got something from the family.
Oh, that's a good point. So ask collateral info
Right.
from EMS.
And then I always try to find out who they got their history from. And if they say, oh, the patient's wife, she's on her way, she was going to follow the ambulance, you figure, okay, so a family member who's an eyewitness probably coming in. Or if they got a cell phone number, well, you know, they're 88, the wife is 90 and she doesn't drive, but you can call her at this number. Okay, well, that's as good as having her here. So
always trying to get like information firsthand from if the patient can't, most times they won't be able to if they're aphasic, dysarthric. Right. So we're talking about the chief complaint is the stroke alert, and the setting is the emergency room. And so what we're going to work through is when we go see the patient, what's, you know, the first part is going to be history. How are we going to get the information? And it's a 60-year-old female, and that's all we know. That's all they gave us. And so now we have to kind of tease out, well, what information do we want to get?
Right.
Doing like a focus history. Seema, does that make sense?
Yes.
Okay, cool. So feel free to chime in. I'm going to be taking notes as we're talking. It's being recorded. This I can send out after we're done. And can go as long as we want. Maybe we can get in 2, maybe get in 3 cases, depending. And then we'll go from there. So
I think most of the time, I think EMS has had a lot of training for time last known to be well, right? So you just say, when was the patient last known normal? And you've probably had this experience already, and I certainly do, where EMS says, well, it's about 1:45 because they called at 1:45. And you're like, no. That's what time you got called. What time does the family think that they were last normal? And if they say, oh, well, I don't know, he was normal this morning when I left at 10, look at the watch and it's 4:30, your time last known well is 10.
Right.
And so, you know, when we're thinking about advanced therapies for stroke, like thrombolysis or thrombectomy, of course, if you're thinking about thrombolysis, they had their stroke 1 minute after that they were last well, right?
Right. If
you're thinking about thrombectomy potential, they had their stroke 1 minute before EMS got there, right? We're still looking at that as being somewhat of a possible window there. So time last known well is important.
You guys can talk while I take notes. I can multitask. So the reason I want to know last known normal is for, you know, T&K, TPA, or mechanical thrombectomy, and other things that would be important. So what's your last known normal? What symptoms, like really teasing out, you know, what's symptoms, big things that I think are important for stroke is, you know, like slurred speech, weakness,
vision loss.
Oh yeah, vision loss, difficulties with speech. Let's see, what else would I want to know from a stroke standpoint? Weakness, speech, vision.
Can't walk.
Oh yeah.
I guess thinking about vertigo or coordination problems. Sometimes we think about the be fast part, right? Instead of just fast was face, arm, speech, time to call 911. And be fast includes balance and eyes. And that, I think, be fast, and that sort of takes me through kind of the fast. I think about it as the fast 5 when I'm doing a stroke scale score, because I don't care so much if you know the left side feels less than the right, or if those things don't matter to me. I want something that I think I can fix with thrombolysis or thrombectomy. Right there, you go. There's be fast. Good.
Balance, eyes, face, arm, speech, time. Balance, eyes, face. Makes sense. I'm trying to think what other symptoms. So yeah, it's pretty much like the important symptoms. What else would I want to know? So we have, what time did it start? What symptoms do they have? Have they had these symptoms before? How long have they lasted? Do they come and go? So that would kind of give us like chronicity, like kind of like old cards. Are they fluctuating?
Mhm.
Are they persistent? How would we call that? Is it just like pattern of symptoms?
Well, yeah, if, you know, sometimes I'll go downstairs and they'll say, the patient's 72 years old, she's had a stroke before, and she's weak on the right from her stroke. She's weak on the right, has trouble with speech, but now she seems to be weak on the left. Okay, that's a new event, right? That's different. If they say, you know, she's weak on the right, but now she feels like she's weaker, that sometimes gives me a little differential diagnosis. Is this recrudescence of stroke symptoms? Did the patient have a seizure and now she's weaker? Is she having a new stroke? What is new at this point?
That's a good point. Chronicity. I know I like to think of like these old cards. They talk about onset, location, duration, aggravating symptoms. Does it make it worse or makes it better? I guess we can kind of put those in here. Old card. That's pretty much all I can think of from a symptom standpoint. And then things that we should know from, if we think, okay, this patient could be a candidate for TNK,
Sure.
if they're in the window,
Right.
What medications they're
That's
on.
right. Perfect.
Are they on any anticoagulations?
Right.
When, if so, what route? What was the last dose? Is there anything else I should know? Oh, indication.
The diabetes and all that, the past history.
Say that again?
Diabetes or hypertension, other chronic problems.
Yeah, like vascular risk factors.
Right. I also think if you know if they've had a heart attack recently, or they've had a GI bleed, or they've had any surgery recently, kind of thinking about your candidacy again, that at the same time you're trying to evaluate them and get a history, if you can figure out, are they a candidate for IVTPA?
I see. So MI, GI bleed, and then like it's like a brain tumor. No, was it brain bleed, right?
If they've had any intracranial bleeding, that I think is a standard contraindication. Like if they've had an old aneurysm or something like that, that's considered a contraindication.
I see. So then B.
Because are you using TNK at the Mayo now? Have you switched all to Nectaplace?
I'm not sure if we completely switch. I know we're in the
Okay.
transitioning.
Okay.
GI, brain bleeds. So we can look up together because I'm a visual learner. So TPA.
Yeah.
Okay, American Heart.
There you go.
So
That looks good.
Contra.
You know, originally, the list of contraindications for TPA 15 years ago was huge. I mean, you've pretty much had 5 people that you could give it to. You know, it was enormous. And then, you know, people started saying, well, there's this kind of relative contraindication, and then there's the definite contraindication, right? So the single really definite contraindication for TPA is bleeding, right? Because it causes bleeding. And then other things you think of around there, is this an absolute contraindication or a relative contraindication to the use of lytic? Your ER physicians generally don't want to make that decision, right? They want to call you, and then they want to let you make the decision, like, I think this is a relative contraindication and I think I would give it.
I'll find the AHA stroke guidelines and I'll put that here.
That looks good.
This will be good for now. So prior intracranial hemorrhage. So absolute contraindications: prior intracranial hemorrhage, known cerebral atriovenous malformation, known cerebral neoplasm. Also, if you have a brain tumor, automatically no.
Yeah.
And then stroke within 3 months, because I guess the concern is they put some high risk for hemorrhagic transformation, bleed. I didn't know, suspected aortic dissection.
So if the ER calls you and they say, you know, the patient actually came in and he was complaining of really bad chest pain. He was complaining of chest pain. And then we kind of noticed that he looked like he was drooping, or said he felt like he was weaker on one side. They get a chest x-ray, right? Or they get that CT angiogram, the mediastinum is this wide. They're like, nah, we better just do a CT angiogram of the chest and make sure that that's not a dissection.
Oh.
Rare, but it can happen.
Is the thought that if the person has an active dissection and you give them a blood thinner, that could just cause the dissection to be even bigger?
You know, the biggest problem is that then they start really bleeding, and they creates a false lumen to begin with, but then the false lumen is larger than the true lumen. And what happens with that false lumen? It goes nowhere, right? It goes nowhere, and a surgeon won't take them to the operating room because the TPA is not really reversible. I know we give 10 packs of cryoprecipitate and things like that, but it doesn't really reverse TPA.
I see. And then some relative contraindications, blood pressures. That's always, I've seen that on step 2 and step 3. My step 3 exam, I had multiple choice, and the question was, which is the following is the contraindication to T or to McCain or antithrombolytic therapy in this patient? And they would trick you because they would say, oh, 185 over 110. And I've seen that many times. So for SEMA, for you, when you're preparing for your step 3s, have you taken step 3 yet?
No, I've not taken step 3.
So for step 3, so know this table well because it shows up on step 3.
Mm-hmm.
Prolonged CPR, history of prior ischemic stroke, major surgery, less than 3 weeks. I know that there's a list of what they actually consider major versus minor surgeries. I have to go and look.
I sent you the link in the chat.
I was going to say, I thought I saw something coming in the chat.
Awesome.
There it is. Nice.
Look this up. Nice. Indications. Oh, thank you. Oh, beautiful.
You're a nut.
The adverse contraindications. Oh, fantastic. This one even goes more. I'm gonna copy and paste this into here. There we go. And then let's see, let's take a look at this together. Come on, is where it go? So exclusion, head trauma or prior stroke within 3 months. We know that one makes sense. Symptoms suggestive of subarachnoid hemorrhage. That makes sense because if you give someone a blood thinner, it could just make the hemorrhage worse. Arterial puncture at a non-compressible site. So I'm trying to think, what would most of arterial puncture is like, well, that's a venous puncture. Like I know sometimes if someone just had an MI and they go in through the cath lab, but they go to the femoral artery, but that's compressible. So that's.
What about the dialysis, the one they make?
Oh, dialysis. Really? Let me copy. So if they've had dialysis within 7 days?
No, if they had a dialysis catheter placed within 7 days.
Oh, okay. This is actually.
Yeah. We used to do the tunneled catheters so much too. You'd have a tunneled Hickman and things like that. I've not seen one of those in a long, long time, thankfully.
I'm gonna screenshot this so we can take notes as we're talking about it.
Look at you. One of these days I'll learn how to do these things. I'll tell you.
So this might be better if I change it to here. I might put it here. I love OneNote because I can directly write on it. So this is for dialysis catheter placement. So if you've had dialysis catheter placement, then that.
Right, because an art line would be compressible. I wouldn't worry about that so much. And I can't think of very many other times that you actually stick something in the subclavian artery, right? I mean, we don't really need to stick anything in the subclavian artery,
right?
In the hospital usually. And
the chemotherapy drugs, no?
Oh, chemotherapy drugs.
You'll put them in a. Well, I guess you could put them in a port, right? But usually, if you're putting in a line, you always hope that you put that line in the vein, right? Because you don't want to be pouring anything into the arterial circulation. You want to pour everything into the venous circulation where you pump it out.
Okay.
So hopefully we're not sticking the artery too much.
I see. So the history of previous intracranial hemorrhage. So that's an absolute, if you've had like, even if it's like 10 years, 20 years, still no T and K or TPA?
I think they're listing it on, this looks like the NINDS list, which is a little larger than the other list that you had. So if the patient had subarachnoid hemorrhage from a ruptured aneurysm, not a candidate. If they have a known arteriovenous malformation, those are going to bleed, right? Not a candidate. If the patient had a fall and had a subdural hematoma, I still think that patient's at higher risk of bleed.
Okay.
If they had a traumatic subarachnoid, that's eight drops of blood up here on the head. And that was gone. I could probably consider it then. I think you get into a little bit of room where you say, is the risk of not doing something higher than the risk of doing something for this patient?
Okay, I see. That makes sense. That makes sense. So intracranial neoplasms, AVMs, or aneurysms. So if we have a brain tumor, no go.
No go.
Okay, that's good to know. Recent intracranial or intraspinal surgery. How do they define recent?
I want to say less than 3 months.
Okay. And then blood pressures we talked about, and I believe my understanding is if your blood pressure is 185 over 110, the thought is, correct me if I'm wrong, but the thought is if you give someone antithrombotic therapy and they have a stroke and their blood pressure is that high, it could increase the risk of hemorrhagic transformation.
Yeah, it increases the risk of reperfusion injury and bleeding. Yeah. At the same time, right, you don't want to make the blood pressure 110 over 80, right? If you can get the blood pressure down, you tell your ER doc, you say, give 20 of labetalol and let's target a blood pressure of 160 to 170, which gives me a little bit of room, gives the patient still, some support for flow, and it gives me a little bit of room giving this medication. I hate it when they call and they're like, their systolic blood pressure is 182. You're like, 182 is going to be 185 with 2 deep breaths. So let's just order some Cardine and see if we can get the blood pressure down just a tiny little bit.
Oh, and I want everybody to note, when I post this up online, I'll say, and I'll put this everywhere, disclaimer, this is for education only, not medical advice. People shouldn't be, using this for professionals, health professionals only. So, FYI. Active internal bleeding. So like a GI bleed or just any kind of bleed. That makes sense. Active bleeding diathesis, including but not limited to, let's see what they say. Oh, wait, now I'm confused. Did they miss something here?
No. It includes that platelet count less than 100, heparin received within 48 hours.
Okay, I see.
That looks like it should have a little tab in. It should be tabbed in.
I see. Okay, so platelet count less than 100,000. That makes sense. That were the Q3. Heparin received within 48 hours, resulting in abnormal elevated APTT. So if they received heparin, but their APTT is normal, can you give?
Yes.
You can?
Yes.
Oh, okay. And then current anticoagulation use with INR greater than 1.7. So if they give, if warfarin, but their INR is less than 1.7, it's okay to give?
Right. Okay.
And then current use of direct thrombin inhibitors. So I remember if their last dose was greater than 2 weeks, do I remember that correctly? Then it's okay to give? Or
I want to say most of the surgeons will take somebody for a procedure if they've been off for 3 days. So off Eliquis for 3 days, off Xarelto for 3 days. We don't see that many people who are on Pradaxa, but kind of a similar thing. The Xarelto and apixaban are the same, right? Hello, factor 10A inhibitors, and then Pradaxa is the direct thrombin inhibitor. So it's important to know. So if they say something like, well, I think he took his dose last night and now it's 11 o'clock in the morning and I don't know if he took the dose today.
Right.
I'm not sure that TPA is safe in that case.
But if it's like 3 days or more, then maybe. Okay.
One of these days we'll come up with a test that's as fast as the INR that we can get and see could they truly get medication. That would be nice. I'm kind of sorry that they've come up with an antidote, which in most cases we're still not using, very much. But before they came up with an assay that we can do quickly and see if they're even a candidate.
And then blood glucose less than 50. And my understanding is because blood glucose, if it's that low, it can mimic stroke symptoms.
Okay.
So you always want to check that and make sure that you're not treating hypoglycemia. Then CT demonstrates multilobular infection. And I'm assuming because that could increase the risk of bleed. That's my understanding.
Yeah, especially if you can see it on CT. Yeah.
The infection.
Infarction.
Oh.
Multilobar infarction.
Oh,
So
I thought
they've got multiple spots.
Oh, infarction. Okay.
Infarction.
Hemorrhage transformation. Okay. And then, so now we go to relative contraindications. Let me screenshot this into here so we can all take notes. So let's see, relative, only minor or quick improving stroke symptoms clearly. Yeah, so I've definitely seen that down in the ED on when I'm stroke service. If their symptoms are improving or they return back to baseline, then there's really no need to give mechanical or TPA. If they're pregnant, a lot of drugs you really don't give if patients are pregnant just because we don't have the evidence to determine if it's safe for the fetus, so we just don't. Seizure at the onset with post-ictal residual neurological impairment. Now, why would that be an indication?
So I think one thing that people are afraid of sometimes is, let's say a patient had an old left MCA stroke, right? So they had old stroke and they have a big area of scarring, and they had a seizure in that left hemisphere from that area of stroke. Then what does the patient look like? They look aphasic and they have right-sided weakness. So, one of the things you can fall back on a little bit, because this is not very valuable to do anything other than, I guess, test and see if your students are listening, right? It really has very little localizing value, is remembering that if the patient had a large vessel stroke, they would look toward the side of the stroke, right? Along with their other symptoms. They usually have gaze deviation and they look toward the side of their stroke, but they would look away from that side if they were seizing, right? So you disable the frontal eye fields on the left. The left frontal eye field moves the eye right, and the right frontal eye field moves the eye left, which is why when I'm talking to you, my eyes stare straight ahead. I guess I could sit in my chair and I could look at you like this, but that would seem kind of strange and weird, wouldn't it? Most of the time we just look right at people. So when you see that patient, if you disable this left frontal eye field, the eyes are not able to go to the right, right? Because that's what the frontal eye field does on the left. It moves the eyes right. And so instead, the patient's gaze drifts over here to the left because that right frontal eye field works unopposed. But if you turn this on,
Yep.
if you seize in this area and you turn it on, what happens? You verse the eyes, right? You drive the eyes right, and then usually you'll have some degree of nystagmus feeding back as well. So if you go in, the ER calls and they're like, I don't know what's going on with this lady. We don't have any history. I don't think she's a candidate for TPA. There's a history of old stroke. And you notice that the patient's droopy on the right and weak on the right. I just realized on camera that looks like left, right? Droopy on the right and weak on the right and looking to the right. Then you think, I think this is a postictal TODS. I think this is a postictal TODS paresis, versus walking in the room and seeing that the patient is looking left with the right side down, where you think, maybe this is a new problem.
I see.
I think the other reason we're afraid of seizure is we're always afraid of seizure, that maybe the patient has a tumor underlying and that's why they seized. Although hopefully, you would see something on the CT scan that would make you think, I think this patient has a tumor.
I see. Thanks. The major surgery is serious trauma within 14 days. I'm assuming you don't want internal bleeding. That's my thought there.
Right.
Or recent GI or UT urinary tract hemorrhage within 21 days. I'm assuming those are just not compressible places that are high risk for bleeding. And recent MI with preceding. Now, why would an MI? Is that? I know with MIs we put people on aspirin and Plavix, but is that why?
So all I can think is that if there was any worry at all that they could have left ventricular rupture, that the patient would basically bleed out. Although if you have enough left ventricular rupture on aspirin, the patient will bleed out too.
I see.
Hey.
I see. Interesting. Now let's see what else this talks about. I guess so that's good. So basically that kind of helps us understand if we go back here, and I'll put in, I'm just going to move to my favorite. I love OneNote, so I'm just going to move over to OneNote.
The hardest thing is always when EMS comes in with this patient and they don't have very much history because they picked them up and swept them onto the stretcher and brought them in, and there's no family there yet. And the only thing that they do know for you is they say, this patient was just in the hospital about a week ago. They actually just got home. They were going to go to rehab and they've been at home, and the wife came home from doctor's appointment and found him like this. And you're thinking, what was he in the hospital for before? What did they do before? How do I know that this might not have been here before? Was he on blood thinners? Was he diagnosed with AFib? Does he have carotid disease? Where then you're kind of going on a fact-finding mission at the same time you're imaging people.
That makes sense. So now, pretty much in the HPI, just really getting information that's trying to help us tease out if the patient is a candidate for mechanical thrombectomy or TPA. We went through all the different contraindications. So past medical history, basically everything from a contraindication standpoint. Medications, the big things are anticoagulations, allergies, that's straightforward. Surgeries, just really
recent major surgery, right?
Or absolute versus relative contraindications for TPA. Social history, I think in the emergency room, there's really nothing important from a social history standpoint. I think the thing, I think one thing I would ask is what was their baseline before they came into the hospital? Because I think that may help with like what's it called, pre-Rankin scores.
Yep, your modified Rankin.
Yes.
Your endovascular people may say, this patient's 85 years old. Were they walking on their own at home? Because if their modified Rankin is 3, they may not take them. If it's lower than 3, then they don't take them for procedure.
Gotcha. The family history, there's really nothing in the family history from a like stroke that I would be wanting to really ask and then vitals. I think the key thing is the blood pressure. And then otherwise making sure they're stable, because if they're not, then, you know, they may need to be intubated, sedated, all that good stuff, which the ED would really worry about. But I'm assuming from a neurology standpoint, though, if I had to get one vital, what is their blood pressure?
Right.
Okay.
And then if you can put them on telemetry where you can see, is that patient going in and out of a fib? That also can be helpful for you.
And then from a PE standpoint, pretty much the NIH stroke scale. And then I was always told, because the NIH doesn't assess for a gait or ataxia. No, it does. We do finger nose.
It does, but you know, if they're weak at all, like if they're less than a 4, like they're a 3, they exceed gravity but nothing else, you won't be able to do good testing, because they don't resist gravity very well. So
anything. So Seema, for NIH stroke scale, that's like, or anytime patient comes into the emergency room, it's a standardized stroke scale that was developed that pretty much any person that comes in, it helps rule in, rule out large vessel disease, really specific for like the MCA territory. And that kind of helps with, as this patient, a good candidate for mechanical thrombectomy. It's a standardized test that everybody does in the emergency room that you'll learn. If you haven't learned it, you'll learn it during neurology residency training. It stands for National Institute. What does it stand for? National Institutes of Health
stroke scale.
And so here's what it consists of. Here's a good one. So basically it's testing level of consciousness, questions, their best gaze, vision, do they have a facial droop, and then motor, you know, do they have any weakness in the left arm, right arm, leg, weakness in the right, left leg, ataxia, you know, we do finger to nose, heel to shin, you know, the best sensory to a noxious stimuli, language, are they aphasic, dysarthria and extinction. And so there's different maneuvers to test all these different components. And then we get a total score. And then that score kind of helps us determine how severe or if they have a stroke, how severe is it? Because if it's what, greater than 6, then they could be considered for mechanical thrombectomy. If they're in the window greater than within 24 hours.
So I think a lot of times you might find this feature at Mayo, your ER will not automatically do a CT angiogram of the head and neck unless the stroke scale score is higher than 6. So sometimes they may call you and they may say, hey, nobody's seen this guy all day. The last time known normal was probably last night at 10:30 and now it's 2 p.m. And he's got right-sided weakness, a little difficulty with speech, not too much, no gaze. Stroke scale score is 6. And you think, okay, well, if it's just 6, do I go ahead and ask them to do large vessel imaging and make sure that they're not a candidate for thrombectomy? Because usually less than 6, they won't do it automatically.
I see. I didn't know.
So you'd have to check with your ER for that and see. Otherwise, they're sending people for this triple study all the time. And at the same time, it's great to always have large vessel imaging. I'd like everybody to have that before they go to the floor. You know, we see enough people with bad kidneys, and you're talking about a lot of dye sometimes if you don't think they're going to be a candidate for anything. So sometimes you say, you know, if they're a 6, there are 1 for dysarthria, there are 1 in the face, there are 2 in the arm, there are 1 in the leg, and there are 1 for sensory. Like this is a small lacunar stroke in the pons, right? Or a small stroke in the posterior limb internal capsule or something. I don't know that we need a CT angiogram and perfusion study if their creatinine's already 1.9.
Oh,
obviously you're always thinking neuron over nephron. We can usually fix the kidney with a little time, but if you don't have to give it because you don't think it's going to make a difference to them in the emergency department, sometimes you use an NIH cutoff for that.
I see. So then that could, I'm assuming, well, I guess that can go in the workup is getting the ED to kind of get like basic labs, including creatinine, to make sure the patient is safe to get contrast. So anything else you would do from a physical exam standpoint besides the NIH stroke scale and just checking their gait?
You know, if they can ambulate, I'm a lot less worried about stroke, because it tells me that their lower extremities are really not all that weak.
Right.
Sometimes I am in the ER when they call for a stroke alert, because they seem to happen in pairs. Sometimes they seem to come in threes.
Mhm.
But if they call me and if I get down there, we have 2 hospitals in the city. If I'm at one, they'll get started with that stroke by the time I get there. Sometimes by the time I'm there, the stroke nurse will tell me their NIH looks like about a 6 or a 7, and we're going to send them for a CT. And then at least once we get them off the table, I can kind of take a look and get the story and things like that.
I see.
Yeah.
So the big things from a physical exam, as long as we do the NIH stroke scale and then checking their gait.
I do think if you cover kind of, for me, the top 5 of the stroke scale are always, how's their language? How's their speech? What does their face look like? And what do the arms and legs look like? Because if you're looking at them and they're gaze deviated, you're thinking, well, if they're gaze deviated, that's going to be a proximal occlusion that's affecting the frontal eye fields, right? I'm a whole lot more likely to have an LVO in that case. And then I want to see what they're doing with that right arm. They're gazing left. I want to see what happens with that right arm. If that arm falls, then the arm's a 4 on the stroke scale score, right? So now I have gaze deviation, which is a 2, and I've got an arm, which is a 4. That's not a leg, that's not sensory, that's not ataxia, that's not speech, that's not language, that's not inattention. I already know I've got a stroke scale score of about 11 by the time I add all those things together.
I see.
Or you go in, you see them looking right, and you say, hey, lift up this arm, and they're completely neglectful of that arm that you think to yourself, let's just go get a picture fast. While they're in CT, you're getting more history for thrombolytic and calling your trusty interventionist.
So instead of trying to do this in order, let me get the HPI first, just really, you see them doing like the quick top 5 NIH stuff first, send them over to
I'll be honest, if you stop them in the room, it takes about 8 extra minutes to get them to CT when you're done. So if you can, if you literally see them on the EMS cart and you're doing a little bit of this stuff, and then you're saying, let's just go to CT. This is clearly a neurologic problem. This is not low blood sugar. This is not psychosis. This is clearly a neurologic problem. Let's get them to imaging as fast as we can.
I see. That's great advice. Do quick. And then go to CT scan. And then I can get the history while the patient's in the scanner. You
can. And in some cases you can get it there, or you at least get an idea just from the exam that you're using, moving. You know, when you go to CT and you're watching the patient, you can see, can they help move themselves over? Or if somebody says, okay, can you cross your arms? You come in, the patient's arm is off the arm's off the cart. They look like they're going to dislocate their shoulder, right? And then you say, okay, let's give you a hug here. And that arm, like, okay, well, there's nothing in that arm. You say, can you take both heels and kind of push yourself up a little bit? And the patient's just neglectful and ignoring you on that one side. You're getting information that whole time. So even going to CT and seeing a lot of that can be really useful. And then getting that first look at the CT, you say, I don't see anything that looks like a hemorrhage. I'm going to call my staff. You're going to be a PGY4 going into stroke. So you may not have to call staff call a senior, because you are a senior, but you might call your stroke fellow or call staff and say, I think I have a large vessel occlusion down here. Stroke scale score is about a 12. Once we get them off the table, we're going to try to give TPA in the scanner.
Right.
And go from there. Yeah.
I see. So the quickest things, if a patient is within the time, if a patient comes in with stroke symptoms and they're within the time window of TPA, the first quickest thing is trying to, see if they have any contraindications. If not, get them to CT scanner, do a quick NIH assessment, and try and get that TPA
get that on board, right?
Possible. Okay.
Right, and then get your vascular imaging if you can.
So
it used to be the golden hour, right? You had 60 minutes, and then they changed it to the golden 45. The inflation, right? Your money buys less all the time, and now it's the golden half hour. But Genentech, by this time, TPA was 20 years old, right? 15 years old. Genentech had said, if you mix TPA in good faith, like you're watching the patient when they're coming by and you're like that, they're taking them straight to the scanner, and you tell the nurse to mix it, and you find out the patient has a bleed, they'll replace it for you. But they're committed. They're committed to getting TPA on board quickly. And so if you say, get the box out of the pharmacy, I think we're going to give TPA, and you mix it to have it mixed, and then you find out something about the time, or then you find out they have a bleed, or they're on warfarin, or they're on Eliquis or something, they'll replace it for you. They don't want to replace 35 doses a week.
Right,
They'll replace it for you.
Okay, I see. So then figuring out ways to be efficient when administering the TPA. Oh, that's really good to know. Another thought you just gave me is talking to some of like the stroke staff about effectiveness within like different institutions. Different institutions run the stroke alerts differently, and really talking to like the attendings, the nurses, and trying to figure out, how can I make this process efficient as a new resident who's going into the ED.
So, one of the most important parts of the idea of comprehensive stroke, as much as primary stroke, but even more so for comprehensive stroke, is what are you doing for community education? Are you getting a hold of EMS, and are you telling them, if you think you have a stroke patient, I need a call out as soon as you can, because one, that gets the scanner empty, right? And two, it gets you downstairs, because they call it overhead, at least they do where I work now, they call it overhead, level 1 stroke alert, 8 minutes by air, 8 minutes by ground. And then what I know is I need to work my way down from the 4th floor, where maybe I'm dictating, or I'm over at the Memorial campus, that I need to get myself downstairs so that I lay eyes on that person when they walk in the door. So you'll get a sense after you've been working in the ER for a little bit, how good your EMS is at really getting a true time last known to be normal, and how much history are you getting that you think is really believable, so that you can get that patient to IV lytic as fast as you can. Or you have to call the team in for a thrombectomy. You may be the first person to see that stroke that's really a big carotid occlusion, last known normal 8 hours ago, not a candidate for thrombolysis, but you'll help to get that patient to thrombectomy so they can get that cleared out.
I see. Seema, if you have any questions, just jump in.
No, I'm actually listening. This is actually very helpful. Yes.
So awesome. One of the things that I have noticed, we saw 2 of these cases in the same day. I had kind of a devastating call the last time I was on call. I think I had 5 24-hour shifts spread out by the just the daytime shift in between that. And I think I saw 47 consults, and I had 10 people die, which is a lot, right? 20%. But I had 2 that came in the same 24-hour period over 2 days, the exact same kind of stroke that ended up being horrific intracranial hemorrhage. And so one thing I will tell you, we left everybody's blood pressure high, right? Because by the time I got into the ER, they said, well, we've left the pressure high because the patient looks neglectful and she's clearly looking the other way. And when patients are neglectful, they don't think there's anything wrong with them, right? They don't understand they've had a stroke. They don't think there's anything wrong with them. But most of the time, your patients who are having an acute ischemic stroke are not terribly agitated, right? If anything, they seem to be more kind of passive and apathetic. And you're like, hey, how about this one? This left arm, lift this arm, lift this arm. They're not swirling around on the cart and trying to walk and things like that. And so when I see that patient really looks agitated and is insisting on leaving, especially if they complain of a headache, I really do try to get their blood pressure down a little bit, because I'm always suspicious that those people actually have a bleed. That the reason they have symptoms is they have something here, but they don't have anything blocked here. They don't have anything blocked here. There's blood there, which is a problem, but they still have normal flow. And so otherwise, they just look different than the ischemic people. Every time I see that agitation or somebody screaming or holding their head, I think you just ruptured that bleed into the ventricle. And that's what happens sometimes. So if I see somebody really agitated who clearly looks stroke-like, I always think about just getting that blood pressure down a tiny bit. Because if they come in and they say their blood pressure is 220 over 100, you can't do anything with that blood pressure anyway, right? The best thing you can do is pull that blood pressure back a little bit and call for cardine, give whatever you have in the Pyxis and call. But sometimes those really agitated people will mess you up a little bit. They're either carotids that are occluded. This has good flow, but this is down, or they're a bleed. They're a bleed.
I see.
Yeah.
I see. Interesting. For blood pressure control, what's your go-to? I know I've seen carvedilol versus nifedipine.
Yeah. So, in the emergency department, they usually have labetalol, and they can give that pretty quick. It's in their Pyxis. And then we usually call for cardine. I want to say that cardine makes an immediate available formulation that you could put in the ER Pyxis, that basically you pull the top off of it and it's a bottle ready to give, which is expensive but worth it if you need blood pressure control and you need the blood pressure to come down fast. And then a few years ago, clevidipine came out. They called that Cleviprex. Now it's clevidipine. It's a calcium channel blocker, very, very powerful blood pressure lowering. Duke did a trial called the Accelerate trial back in, I think, 2006. It took them a year to recruit enough people for it, because 50% of the people in the trial came from outside of their hospital, right? And cardine's on the rig. And so that's what people had been exposed to. And it'll take 30 points off the blood pressure systolic in under 2 minutes. I mean, it's like a curve straight down. And that can be very useful too. It's something that's very titratable. So is cardine, that you can have when they go to the endovascular lab, because once they get that vessel open, they don't want the blood pressure 220, right? So when they've placed the stentriever and they're waiting, they're giving it that 5 minutes. That's when you're titrating that blood pressure down, because when they pull that catheter back and there's a clot in it, they don't want that thing to just blow up.
Right. That makes sense.
So I like that. And then if you send them to the ICU, they're still usually on cardine. I guess you could use, we used to use Esmolol. That was Brevibloc. I'm not sure anybody knows what Esmolol is anymore. Things have changed a lot, right? But
I've heard of it, but I've never used it.
Yeah, it's Esmolol is another rapidly acting beta blocker that is very titratable. It's only available IV. So it's very useful for people who have dysautonomia, Guillain-Barré syndrome and things like that, or drug overdose actually is the other scenario I've used it. You hang Levophed and you hang Esmolol for the same person. You just say, you better behave yourself because we're gonna play around. But we generally try to get people on something oral within the next couple of days. One of the biggest mistakes I see is that, especially when people do well after TPA, is they're downstairs on the medicine service, sometimes just 8 hours or 10 hours, and then they're sent home on 3 medications for blood pressure, and that's way, way more blood pressure control than they need.
Right.
If they came in with a blood pressure of 180, if you can get them down into 150, 160 with frequent follow-up with their family doctor, I don't think you need to send them home on 3 agents. You can send those people home on lisinopril or lisinopril plus a little Norvasc. How many of them are diabetics that don't know about it? So the lisinopril is good for that. And then a little bit of Norvasc, and then have them follow up and have them get a blood pressure cuff and checking their blood pressures at home and writing those down. And the best thing is when you see them go from 150s to 140s to 130s to 120s over about a 5 or 6 week period. And now they're basically in the 120s. And you find when you get those people down into the 110s, they can't do anything.
Right.
They want to exercise or they want to do stuff around the house and they can't because they're kind of dizzy and they don't feel well, and maybe they fall or something like that. So I wouldn't overtreat the blood pressure too much.
Thank you. So let's see.
Olive?
We've done asking the questions. Anything else to see done? We're doing the physical exam. So now the workup that we want to get.
What about memory? Do we test memory?
Memory? No, I think for a stroke patient, that's kind of included in the NIH stroke scale. Basically, the question you're asking is how old are they and what month is it?
Right, what month is it?
And that's like this. So that gets into the memory, but we're not doing like a full detailed, are you alert? What's the year? What, because I think what the NIH stroke scale is trying to do is trying to streamline what are the basic questions we need to ask. and then move on so that we can get them to CT scanner and get them to the TPA, TNK, or mechanical thrombectomy. But what you could do once you do that workup and they go to inpatient, then the admitting team can then go back and ask more detailed, memory questions and tease that out more. But from an NIH stroke scale, the only two memory questions are age and month.
So sometimes you're lucky and you've made a decision, right? You're going to give TPA and it's running, or they're going to go for thrombectomy, and then the family comes, right? So the wife is there, the husband, the daughter, and you can find out from them, how is this patient at home? Who lives with them? Well, they live by themselves, but I go over every day and I do the medication box for them, and I make sure that that he's got plenty to eat. I always send dinner home every night. Well, then dad's not able to do as much for himself as he was before, right? Maybe they're doing the finances, things like that. You just ask, are they safe to be alone during the day? How's their memory? How are they cognitively? Do they walk with a walker or a cane? And you get a little picture in your mind of how is this patient otherwise. And I think that information is good practical information, because I think it helps you with your early discharge planning. You say, if this patient really wasn't doing well on their own ahead of their stroke, they won't be any better after, right? They won't be better than they were 5 minutes ahead of having a stroke. And that way you can kind of get started with rehab planning and discharge planning and things like that.
So once we're done asking the questions and we're doing our exam, we're concerned that the patient's having a stroke. The most important key thing is to do a CT head without contrast.
Right.
And really what we're looking for in a CT head is, do we see any evidence of infarction? Because if they're already infarcting on CT, then there's really nothing for us to kind of save.
Right.
So, but I know they do like an aspect score.
They do. Do they do the aspect score for imaging where you are?
Well, they do it just like in talking out loud, but usually we're always getting a CTA anyways.
So where I'm working now and where I was before, Mayo's an Epic facility. Now I'm at a Cerner facility. St. Luke's was an Epic facility, which was great. And so they were able to put a build in that the ER would order something that they called CT stroke alert. And what that meant is, 1, it went in as a stat study, and 2, it would say call aspect score on it.
Oh.
And now the interesting thing is some of the computer on that through McGill up in Canada. I think Goyle is still there. But I think the aspect score is very useful. And so if you learn the aspect score, I think just the process of learning it helps to kind of attenuate you to what to look for on the CT. And it helps you when you're looking at it with the ER. The ER really wants to learn. I know we make jokes about the ER doctors all the time, but I'll take an ER doctor over 10 nephrologists. You know what I mean? Because ER guys and gals want to learn. They want to know. And I had an ER doc call me one day, and he told me, he said, this patient has a hyperdense MCA sign, and I think the carotid's occluded too. And he was right. And, just showing me he's looking at his own imaging and everything else. So the longer they've been in practice, the more interested they are in knowing. But I think the aspects is a great way of showing people what you're talking about, where you say there's blurring of this gray white margin. That's an early sign that there is something in this hemisphere. So I think aspect scoring is very useful.
I see. And then as I understand with the aspect score, if they have normal is 10,
right?
That's right? And as we start to see infarction or gray white matter changes on the CT, if we see it in certain regions, then they get 1 point off. And then as they get points off, if the aspect is greater than 1/3, or
so if the aspect score is less than 6, I don't, there's a clinical trial called Tesla, like the car, that I think is looking at thrombectomy and aspect score of 3, 4, and 5. If the aspect score was less than 6, our people didn't go, because what they said is there's so much of the brain that's infarcted already that you have to go through, frankly, infarcted tissue, right, in order to get any improvement, and you're more likely to bleed.
Okay.
But I think what they're trying to do now is acquire more data that says, if you tell the family we're doing a clinical trial. We're looking at these things that we have never looked at treating before. And if you're interested, we'll randomize for clinical trial because they're not a candidate any other way. I think we may be able to collect a fair amount of data that way.
I see. And so how to calculate the aspect score? Sometimes this is something that neurology or radiology will do, but you know, when you're looking at your own CT scans, you're looking at different regions in the cortex, you know, and then the middle MCA territory, you're looking at the basal ganglia, internal capsule, caudate, putamen. And if you start to see evidence of dedifferentiation on CT, and if it doesn't have a nice gray white matter architecture, then you give it a 1. And so I love MD Calc. So here you can just kind of put in the scores. Do we see abnormalities in the caudate? Yes, then you go from a 10 to a 9. Internal capsule, lentiform nucleus. So this is saying 27% chance patient with aspect greater than 8 will have a modified Rankin of 0 to 1 in 90 days. Anywho, so what they're really using this aspect score, from what I understand, is if they're a candidate for for thrombolytics and for mechanical thrombectomy, right?
There's some data that says you can have a certain amount of gray-white interface blurring and still be a safe candidate for IVTPA.
Oh, okay.
So I don't know that I would give it for an aspects less than 8. Less than 8 indicates you've already gotten multiple spots that have been affected, right? And if you have a frank stroke there, like here's a big hypodensity in the basal ganglia, I don't think I would give that. If you have gray-white interface blurring, I think that you can go with.
I see. And I'll send this out.
But I think the aspect score is very useful because I think it helps you look for a specific group of areas that could be bothered, because you know you're looking at this, and the scan of course has already been sent off to Nighthawk Radiology or something, right? Might be read by a neuroradiologist, might be read by a general radiologist. Nothing wrong with a generalist. I'm a generalist, but in some cases they send this thing off and the reason for scan says headache or it says stroke. It doesn't say right-sided weakness and aphasia. It doesn't say left-sided weakness and neglect. And so here's this radiologist saying, well, I'm gonna read what it is that I see, and I don't see anything obvious. You might look at it as a stroke fellow and say, I'm looking for something in the left hemisphere, and I think there's a lot of blurring. You know, I've localized where this should be, and I think I see changes where it is. Am I going to treat it or not? So I think having that in your armamentarium is useful. And you know, if we are always dependent on somebody else to do things like this and they're busy, or something happens, or somebody doesn't get a page or whatever, we're waiting and waiting and waiting to make a decision. So if you can do some of those things yourself, I think that's even better.
That makes sense.
Run with the big dogs, you know?
And this is going to be a question that they'll ask you on step 3 is, why do we get a CT head for a patient with a stroke? And the big thing we want to rule out is make sure they don't have a brain bleed. Because if they have a brain bleed, that's a different algorithm that you work through, and they're definitely not a candidate for TPA or TNK. So why we get a CT head is to rule out brain bleed. And brain bleeds are big and they're hyper dense on CT scan.
Right.
Let's see. So to rule out brain bleed. And if they don't have a brain bleed on CT scan, well, okay, cool. Then we can start making sure that they don't have contraindications for TPA, and then pushing it. Now we're concerned for stroke. We don't know why they have a stroke. So there's many different etiologies for stroke. Some of the main etiologies are large vessel disease, where do you have a big honking thrombus in your internal carotids, or in your MCA, ACA, PCA, or do you have like a posterior circulation stroke? So that's why we get a CTA angiogram to where they put contrast. They're looking at the big, large vessels in the brain to see if there's any blockage. Because if there's blockage, and they're within 24 hours of symptom onset, well, then they could be candidate for mechanical thrombectomy, where the neurosurgeons go and they go through the femoral artery and they can like retrieve is it the femoral artery or the arm? We're
doing all of ours through the groin.
The groin, okay.
Yeah.
Where they can basically go and remove the clot from the circle Willis. So that's why we're getting the CTA. Now, I know one thing I'm confused on is most times we're not getting perfusion studies, but I don't know when to get a perfusion study or when to not get it.
So when the first study looking at CTA of the head and neck and perfusion study was the Diffuse 2 trial, right? And St. Luke's, my hospital, was actually the only CT site, which was very exciting. And so for a while, it seemed like we were getting CT angiogram and perfusion on everybody.
Mm-hmm.
And even when I left there, which was just a year ago, if you did the angiogram of the head and neck, you got the perfusion study too, unless you felt that the patient was so impaired from a nephrology standpoint, from a nephropathy standpoint, that they could not have the extra contrast. We just got all of them. The perfusion study tells you, do you have viable brain to go after, right? The CTA says, is there a large vessel occlusion? And if so, where? And the perfusion says, is there viable brain to go after? So I think if you have a patient who comes in, because this is classic, right? That somebody goes to bed at 10:30, it's a man, and he gets up at 3 o'clock every morning to pee, right? Every morning, like clockwork, he gets up and he gets out of bed and he falls out of bed because he's neglecting his left side and doesn't realize that he can't walk. So his wife calls 911 and he gets in, and you run in at 4:10 in the morning and you say, when was he last known normal? And she says, he was normal at 10:30. And then he went to bed and then got up to pee, and then this happened. He was normal at 10:30. Well, that patient's within a window for thrombectomy. You don't have to have the perfusion. You could get the angiogram and then go from there.
Okay.
If the next day the daughter goes to the house and finds her dad by the bed, and you say, when was he normal? She says, I had dinner with him last night. He was normal when I left, and that was 9. Well, now it's 11:30 in the morning. You don't know if you have any brain left to save there, right? You don't know what that brain looks like. And for that, I would get a perfusion scan.
Okay.
Because even if you find the occlusion on CTA, you don't know that there's any brain left, because you don't know anything about the collateral circulation, right?
I see.
So I know Dawn and Diffuse say that you can go up to 24 hours, but what's one of the caveats of that study, right? About 77% of patients in there only had a time since last known well of 16 or 17 hours. They went to bed at 10 and they got found the next day around lunchtime. They weren't going to bed at 10 and found on Monday, you know. Yeah, so I think the perfusion is very useful for that, to give you an idea of, is there a match deficit, or is there brain left? Is there really a penumbra still?
Sounds like good to really get in patients with the wake up stroke.
Yes.
Okay.
Yes. And honestly, you know, I'll be honest, I always think this, because CT is just one of the busiest places in the hospital, right? Those people have a thankless job. They're just on the table, off the table, on the table, off the table. That if you're getting the study, just get the perfusion.
That's a good point, because
if you're there and the patient's in the scanner and you already have IV access and they already have a bottle of contrast, then just get the whole study and send it send it through and have an idea there. Yeah,
that's a good point.
Because you know the thrombectomy procedure is not without risk, right? All procedures have risk. Drawing blood has risk, and so you hate to see a patient who may have really bad atheromatous disease, and you send them for a procedure, and then you figure out you can't really do anything to help them, and then you've put them through a procedure that could be harmful. I think it's better to get the information, and then you work on helping the kidney to recover. You know, most people, we joke about putting people on dialysis after stroke workup, but that's not really true. For the vast majority of people, that isn't true.
I see.
Look at you, you nut.
Then let's see. So we do CT head, CTA, head and neck, CTP. And if the patient has a large vessel occlusion,
Right.
they have penumbra to save, then we would pull the mechanical thrombectomy alert,
Right.
get all those people in. Cool. I think so. Plan if candidate for mechanical thrombectomy, then call alert. And each hospital has their own different protocol for like
Right.
the mechanical thrombectomy alert and then the stroke alert. And our role as neurologists in the ED is really, doing all this workup and figuring out, is it a stroke? Yes, no, or they're stroke mimics. If it is a stroke, are they within the window for TPA, TNK, or mechanical thrombectomy? If so, pushing mechanical or TPA, making sure they don't have any contraindications for that. And then if they're candidate for mechanical thrombectomy, getting the right people involved so that they can, get that done as well. So since that maybe give me an idea, stroke mimics. So sometimes patient comes in and they have left-sided weakness and they can't speak. There's stroke mimics. So along with thinking, could this be a stroke? We have to be thinking, well, what else could it be if it's not a stroke, so that we don't get, stuck in that this is a stroke and miss something else. So some of the stroke mimics that I'm aware of is Todd's paralysis, hemiplegic in the setting of seizures, hemiplegic migraines, hypoglycemia. What else could be a
I've
stroke?
worked in MS, so I've seen MS.
Oh, MS. What else? What else could be a stroke mimic? I think those are the major things. Anything else that we missed, Doctor?
I don't think so. So I've not seen many people with hemiplegic migraine, but I have seen people who have what we call like complicated or complex migraine. Usually they don't come in plegic, but sometimes they'll come in with facial numbness and strange speech, or more often they have visual complaints where you need to say, so you had this weird thing over your vision, and then your head started hurting. How long did that take? Well, 20 minutes maybe. You're thinking, this sounds like a migraine with aura. This doesn't really sound like a stroke. This sounds like a migraine.
I see. Awesome. I think from a stroke, did we cover all the big acute things that need to be done? Talked about HDI.
We have a lot of stuff. The one thing I will put in here, you can put it in as a stroke mimic, although I don't think it's really a stroke mimic, but we started at my old hospital, and we're doing more of that at this hospital, always looking for a susceptibility study on MRI. It's the GRE study or the SWI study, looking for amyloid angiopathy, right? Little tiny micro hemorrhages in lobar regions, because we definitely see people who have those kind of, they call them amyloid, they're not TET spells, that's the heart, but what we used to call sort of amyloid spells or amyloid events that we think are probably due to a very small hemorrhage in patients who are not on anticoagulation. The hemorrhage is very controlled. It's too tiny to resolve on CT most of the time. They're very, very difficult to see acutely, where patients are weird for a period of time and then they seem to be better. But I always think in adults that are over the age of 65, if you get an MRI of the brain, even getting one without contrast, get a GRE study just to see, do I see small areas of bleeding?
I see. So in your practice, when the patient, if they get admitted to inpatient service, when they get that next day MRI, just always go ahead and get MRI brain without.
I always get a GRE.
Okay.
I always get a GRE. I don't necessarily need the contrast so much because I'm not really looking for a brain tumor unless I think, I want the contrast because I want to do a coronal study looking for mesial temporal sclerosis, or I do want to look for demyelinating disease. I want to see if this could be an MS exacerbation, or I want to make sure this isn't a tumor. But I always make sure that there's a GRE study in there. I actually think that should be part of every MRI sequence, because to me, that helps to direct management if you're going to put a patient on anticoagulation or not. If you get this thing back and you see 100 little spots and you're thinking, I can't anticoagulate that patient, they'll have a bleed and then they'll really have a big bleed. That's a patient who needs a Watchman or a lariat procedure or something like that.
I see. But in the ED, it'd be hard to determine if the patient has underlying CAA.
It is. It is. That is true.
You can't pick that up on like CT or CT.
Don't. You don't. Yeah. So that's something where you say, okay, the patient came in, although those spells tend to be short-lived, right? The classic part is they had something at home, EMS came and they saw it and they brought the patient in. And by the time they came in, their stroke scale score might be 1. And you're thinking, well, I'm not giving TPA to something that's rapidly improving, right? Because this could be a TIA. Let's bring him in, admit to hospitalist medicine, and then let's work this up and see what happened. Get an MRI of the brain with a GRE study, and I would look for CAA.
I see. Fantastic. This was wonderful. Thanks, everyone. So, Seema, I chose stroke workup. What case would you like to run through for emergency neurology? Like what chief complaint? You can pick anything you want.
I've actually worked in MS, so I don't know if that qualifies as emergency, but I've seen.
Yeah, we could do like vision changes and like an optic neuritis. That could be a chief complaint. Well, I guess a chief complaint would be vision changes and a patient that we know has a history of MS.
My most difficult ones are polyneuropathies. I always get confused with polyneuropathies. I know they don't qualify as emergencies, but it's always.
How can we turn a polyneuropathy into an emergent? I guess polyradicular, we could do like a GBS case.
Yeah.
Isn't that a polyradicular neuropathy?
Right.
Cindy?
If you got paid by the letter, that's what you'd say, everything, right?
True.
Yeah.
Cool. Okay, let's.
Can you share this on the chat?
Yeah. I'll type this up. I'll make this more pretty in a Word doc, and I'll share maybe a Google Drive. I'll figure something out to where it's shareable. So
the one other thing I would do where you have your workup down here, right? So your CT and your CTA were done emergently. You wanted those for right now. But one of the things to think about for the inpatient, if you make yourself a little thing that said, what else am I thinking about inpatient for this, is to make sure that you check an echocardiogram, and in a patient less than 65, I would make sure to get a bubble study looking for a PFO.
Like a TTE versus a TEE.
Correct.
Definitely.
Correct. So, depending on the size of your facility and how many cardiologists you have and things like that, sometimes an inpatient TEE is not always a realistic option. And especially in a younger person that is well formed and hasn't already had a sternotomy and things like that, sometimes the TTE with a bubble study can be a very effective study looking for a PFO. But I think that is useful, especially in cases of young stroke. If you're a 28-year-old woman and you have a stroke, you really want to know why. It doesn't help somebody to be like, be good and don't have another stroke. You're like, what the hell? What am I supposed to do to avoid having another stroke? So I would always think about doing that on the inpatient side, a bubble study for every person who is younger.
And then there was another thing I was going to ask. Oh, so when we're pushing TPA, whether or not we do aspirin, Plavix,
right?
Do we load with 325? Do we load with, is it 75? Plavix? And I'm trying, so is it the AHA or the stroke guidelines to have like a really good I want to say
that AHA has a good secondary stroke prevention paper that is on the AHA/AHA website. I think it was published in Stroke, but it's on the website. There have been a whole bunch of studies. There have been studies looking at loading people with Plavix for TIA clinic. That's the POINT trial. There's been trials looking for silostazol using Plital and things like that. I think the industry standard is we're using aspirin unless the patient has a stroke on aspirin, in which case they need something that works better than aspirin. And then we are usually using DAPT for 3 weeks. We're using dual antiplatelet for 3 weeks and then transitioning to Plavix monotherapy.
Okay.
And that gives you actually a little bit of time to get cardiac event monitor on somebody to see if they have AFib, right? Sometimes you'll see somebody, they clearly had a large vessel stroke, or you'll get the MRI and they have an anterior branch MCA and a posterior branch MCA. And you think, I think that might be a clot that just lysed itself. I think this patient may have AFib, and I want a cardiac event monitor sooner rather than later. Most of us don't want to put people on anticoagulation unless we have a good indication to, right? Because if they have a bleed, then what are you treating? You don't have a diagnosis yet. Mm-hmm. But if you see a patient who has what looks like a large vessel stroke, or they have stroke bilaterally and in the anterior and posterior circulations, or evidence of an old cortical stroke that maybe they didn't know they had, which really starts to increase your suspicion of atrial fibrillation. You get an echocardiogram, they have biatrial dilatation. You think, whoa, I'm starting to see a lot of evidence that this patient has paroxysmal AFib. And so I want monitoring, and then a decision for anticoagulation.
Thank you. Cool. So probably when the next times we do emergency neurology cases, we can talk about dual and more detailed dual antiplatelet therapy.
We could. That's always a good topic. Yeah.
So then I will stop sharing my screen and then prep for. Oh, we have another person join. Hi, if you would like to introduce yourself.
I'm going to step outside of my camera for 10 minutes, but
okay.
I'll be on phone.
Is it your last name, Forbes? Oh, hi. Welcome to our study group.
Huh?
No problem. I think you had reached out and sent me an email. You're welcome to tell us who you are, where you're located. And we're doing some emergency neurology cases, and we're getting ready to move to a second case. Thanks for joining us. Oh, do you have 2 cats?
I have 4 cats.
Wow.
But 2 of them really love the computer.
Oh, that's so cute. That's so cute.
This is fun.
My boyfriend, he just adopted a new kitten, because what happened was he was parked, and then this small kitten just like jumped underneath his car, and he's like, what's making that noise? It's making that noise. And he found this cute little kitten, and he's like, well, this kitten is so cute, I have, it didn't have like a collar. He thinks it was a stray or cat.
It got separated from its mother or something like that. Right. It's kitten season, I'm afraid.
Yeah. So he's been nurturing the kitten for the last couple of months.
Kittens are cute, aren't they? Oh, they're so cute. They're so cute.
Let me see. So I'm gonna go ahead and save this real quick. This is stroke. Give me 1 second so I can prepare the next sheet. Stroke alert. Stroke alert, ED. So we're going to do CC, we're going to do weakness. Let's just do weakness. Oh, awesome. Oh, cool. Aspiring neurosurgery and studying pre-med at the University of West Indies in Barbados. Welcome, welcome, welcome. Exciting. So I just want to let you know we're recording, if you're okay with that, just so for people who are not able to make it, I'm going to put this up on YouTube, and people can go back and watch it. I plan on rewatching it as well for note optimization. and learning. So FYI. So now I'm going to share my screen. And let's see, share screen. And we're going to do a new we're going to do a new chief complaint, which is, what's a good chief complaint for? She said polyneuropathy.
I think it could be weakness, but I think the other thing that we see a lot, if you are concerned about Guillain-Barré syndrome, is sensory change. People have paresthesias in the legs that are sometimes painful, like in the feet and legs.
So how about we make that the chief complaint? I think I spelled this wrong. Paresthesia. Okay. Leg. Well, that's a good one. Leg. Pares. There you go. And the setting is ED. And let's see. HPI. Say the patient is 40-year-old female. Well, let's make him a male. 40-year-old male. So with the things I would be interested in knowing, if you have feet and leg paresthesia, I like to work from like a differential. So when I see this chief complaint, what should I be thinking of in the emergency room setting that I cannot miss? So feet, leg paresthesia, if it's unilateral, you know, could it be like a vascular, would unilateral cause? Yeah, could be no, because if it's a stroke in the spinal cord, that'd be more like bilateral. But
yeah,
it could still be like a stroke in the brain, but usually stroke doesn't cause paresthesias, right?
True.
Well, I guess if it's in the in the post central lobe, you get all kinds of abnormal sensory findings.
But I wouldn't expect it bilaterally then.
Okay,
so I think one question is it in one leg or both?
Okay. So
I think this is a situation where your old CARTS mnemonic would work good here. So when I was in medical, we called it PPQ-RSTA, which was like provoking, palliating, you know, time course of events and things like that. So if that's the mnemonic old CARTS that you use, like when did it start? How long does it last? What makes it better? What makes it worse? You know, those types of things and associated symptoms. I think then that gives you an idea of how you can localize it. And then decide from there, what do I think could cause this?
I see. Is it Rady? I'm not a good speller. Glad they have spell check. Oh. There we go. It's coming. Aggravating, radiating, temporal. I can't remember what S stands for. Maybe other symptoms. Okay. So if the patient comes and tells us that he's having unilateral symptoms, then I would, you know, from a differential standpoint, think, could this be stroke? Could it be, you know,
right,
from CNS down to the spinal cord? So unilateral feet, leg paresthesia, could it be like a radiculopathy?
Sure.
Yeah, I'll just kind of work my way up. Work my way up from the localization standpoint. Wouldn't it be a myopathy? Wouldn't it be a neuromuscular junction issue? Could be a single peripheral nerve. It could be going up from nerve. Then we have our roots. Talked about that. Could be a ganglionopathy, right? If it hits multiple regions. We're doing your favorite. We're doing chief complaint, leg and feet paresthesia.
We're thinking about a plexus.
Oh,
plexopathy.
So where we're now at, SEMA, basically, patient comes in. The chief complaint is leg and feet paresthesia. Our settings in the emergency room. 40-year-old male. and we're just trying to figure out what questions we would want to ask this patient in the emergency room. So a mnemonic I learned is old cards: onset, location, character, aggravating symptoms. I think this is relieving symptoms, not radiating. Temporal, kind of like when did it start, and then other symptoms. And then now we're coming up with a differential. If the patient says, oh, it's only in one foot, well, then our differential is different than if it's bilateral. So right now we're working with a differential for 1 foot. So if it's unilateral, then it could fit a stroke with the sensory findings. If you're hitting the post-central gyrus on the opposite side, and then just working our way up from a localization standpoint, it could be spinal cord. No, actually, spinal cord would be bilateral, right? Like,
You could have a Brown-Sequard syndrome, but I would expect then that you would have weakness with it.
okay.
Yeah, I'd expect then that you'd have sensory ipsilaterally and, I'm sorry, weakness ipsilaterally and sensory contralaterally.
And then we're thinking, it wouldn't be a myopathy, like going from a localization, working way backwards. It's not a myopathy. It's not a neuromuscular junction. It could be a peripheral nerve. Could be radiculopathy, like you brought up earlier. Could be plexopathy. I'm a visual learner. Let me show localization neurology. That's why I love neurology. Neurology localization. Let me see. There's a good image.
I think even for the plexus, you would probably have a fair share of weakness too. Just you could just kind of stream of consciousness and then kind of try to refine your differential a little bit. Oops.
So do plexopathies usually have unilateral or bilateral? I thought they were bilateral, no?
The plexus doesn't have to be bilateral. The plexus can be unilateral, but usually you'll have weakness as well.
Okay.
Where are you?
Oh, I can't find a good neurological localization from like muscle to brain, but I'll look for that.
Let me see
later, and I can show everybody. So plexopathy, radiculopathy. Which one comes first? Radiculopathy comes first, then plex, or is it plexopathy then radiculopathy? Like I'm working backwards. So from the muscle, neuromuscular junction, then we have the single nerve, then we have the root, or is it plexus?
The plexus is made up of the roots. So I think the question on the radic will be, do you think you have a 4-5 radic, right? So you'd expect sensory change in that pattern, as opposed to a plexus where you may have weakness and sensory change in the distribution of multiple nerves.
I see. So a plexopathy is made up of multiple nerve roots.
Right. So the
lumbosacral
plexus.
plexus.
Right.
Okay.
Right. Exactly.
I see. Thank you. So it could be peripheral nerve plexopathy. Could it be ganglionopathy with the?
Could be, because those are painful.
What about myelopathy? No.
You can. From cord, I'd expect you'd probably have some weakness as well.
So with,
but you wouldn't, I guess you wouldn't have to. You can think of the anterior spinal thalamic tract being more involved than the lateral down further distal corticospinal tracts.
So radiculopathy, you would have pain. So cool, awesome. So I think, and then we could be spinal cord. Cool. Then now, if we have bilateral symptoms, so we could think spinal cord infarct.
Mm-hmm.
Oops. But that'd be a myelopathy due to a spinal cord, right? Then the etiologies would be spinal cord
And I'd expect you to have weakness as well, although you know, this is just what the ER calls you about, right? They're like,
Yeah.
oh, we got somebody with tingly legs, and they don't know if the patient's weak or has reflexes, and they haven't scratched their foot, and
Right.
haven't done a rectal exam, and haven't stuck them with a pin. I mean, they haven't done any of those things yet, right? Because they saved all that fun for you,
Oh, goodness.
because you, neuro nerd, brainiac, that's the kind of stuff you want to do, is poke the patient with a pin and do all these things.
Make note of that. So it could be myelopathy, bilateral symptoms. What would cause bilateral symptoms? Could be work my way up, not myopathy, because myopathy doesn't cause sensory issues, not neuromuscular junction. Could be less likely a peripheral nerve for it to be bilateral, unless the process is hitting, you know, a lot of the, you know, peripheral nerves.
If you're thinking about it like a multifocal motor, mononeuritis multiplex or something like that. Like you have a peroneal nerve on one side and a tibial on one side and carpal tunnel on one side, right? In the setting of a vasculitis or something like that, systemic vasculitis.
You know, you were going to say something?
No, I was thinking of the posterior, like pontine or cerebellar. I was going upwards. Yeah, we're still near the spinal cord.
Say that again?
I said I was going upwards towards the brain, causing the bilateral symptoms, but we're still at the spinal cord.
Oh, okay.
Yeah.
Some people like to go from up down. I go from down up. It's interesting. So, and then it could be, if it's a radiculopathy, it could be radiculopathy, polyradiculopathy. It would have to be polyradicular.
You could see a patient who had very bad spinal stenosis, who had pain radiating into both legs, or caught Aquinas syndrome with pain radiating into both legs. What did I do here?
And then after polyradiculopathy, it could be a plexopathy, but it would have to hit both plexi, which is, wouldn't be a plexopathy, because plexopathy usually is unilateral, right?
Usually.
Okay, so then we'll leave that out. Plexopathy, gangliopathy, those are usually unilateral.
Unilateral.
Okay, so we leave that out. Then after the ganglion, then we have the myelopathy, which we talked about, and then could be what were you mentioning, Seema? Now we're in the brain.
So I was talking about any of the upper motor neuron lesions, right? Any of the UMN lesions would be bilateral.
Okay, so like bilateral. So what lesions would hit, what brain could cause bilateral symptoms in the lower extremities, in the legs?
In the legs, yeah.
Because if
So
we would have to have other symptoms, like it, not just leg involvement. Because if we're hitting both the legs, then you have to hit that. We'd have to hit the ACA on both sides, or be like
if it hits the corticospinal tract, then it would reach, right?
Oh, yeah, but you have to hit both tracks at the same time.
So there's a certain share of people who have something called an Azigus Aca, which means the ACA comes off of the other carotid, right? So you'll see the carotid come up behind the eye, and yet the ACA from the left also serves the right, just as an anatomic variant. But I would expect that the patient would be weaker more so than have paresthesias.
I see. So this would more so cause weakness.
What are you doing? Brown's coming to say hi again.
Aw.
He found a rubber band that he's been playing with.
Is
And
it
then he likes
Carol,
to-
Tony? I'm not sure if I'm saying your name right. I apologize if I am. If you have any questions, just feel free to chime in, jump in. Put it in the chat. It's very informal. Paresthesia.
Saying hi.
Hi, Kitty. Oh, that's so cute. Awesome. So now we have our differential. So now, based upon our differential, really going to tease out. Actually, Seema, this is your chief complaint. I'll let you run it. I'm going to keep quiet, and I'm going to just be typing.
No, this is actually one of the difficult things that I always struggle with when I'm trying to localize the lesion. So that's why I wanted to learn about this.
So if this was your patient in the emergency room, what things would we, what besides what we've already talked about, what things would you want to know? No, we can all chime in.
Other systemic symptoms, like if you have any vascular or skin dermals.
Systemic symptoms. So we like skin, vascular. For me, what helps keep me organized when I'm asking questions, I focus on I get all my neurology questions out first, and then based upon what I think the differential is, based upon what they told me from a neurology standpoint, then, kind of going into some of the other systems that could support or rule out my neuro stuff. So if we focus on neuro, onset is key. Is it acute?
Right.
Subacute, chronic, because if it's acute, that makes me think more maybe vascular. If it's subacute, then we're thinking, it's just more like a slower polyradiculopathy, more like a Guillain-Barré type thing. If it's chronic, then I'm sure it changes the differential. So I've always been taught in neurology, onset is extremely key because that helps with, we also have like hyperacute, that helps with your differential. Localization, patient tells us he's only having symptoms in his lower extremities. He tells us it's bilateral. So when we hear that, we think, okay, well, we're looking at these symptoms here. What else would we want to know from a location standpoint? One thing that I've learned in neurology is to be as specific, as detailed as possible. So when they say, oh yeah, it's in my leg, the younger me would be, yeah, it's just in the leg. And then my consultant would be, okay, so but where? Is it in the front? Is it in the back? Is it in the side? Is it in the middle? Is it proximal? Is it distal? Like where? So I've always learned to just be like hyper, like give me detail, give me the detail. So in location, really being as specific as possible and really like holding down, well, where is the pain and having them point. So he says it's in his toes and it's his feet. But you don't want to stop there. He's like, yeah, it's in my toes and my feet, but where? Is it on the lateral, medial? Is it on the dorsal? Is it on a plantar? Because if we look at the innervation of the feet, if we go to the sensory, the different roots innervate the feet. So that's why it's key. He can't just tell us, oh, it's in my feet. Well, what part of your feet? Because if it's the medial aspect, then you have a different set of nerves versus the lateral aspect versus the top versus the bottom. So being like as specific and detailed as possible is key. So he says it's really in his toes, and it's his feet all over. It's the back, the front, the side, the middle. So just being detailed. Trying to think, what else would I want to know from a location standpoint? Yeah, having them point. That's what I typically do. This is also a good thing when characterizing the symptom, characterizing the paresthesia, and that, well, what does it feel like? Because sometimes people say, oh, they'll say my feet feels funny. And there's a difference between, oh, my feet is numb versus my feet has like shooting electric jabbing pain versus my feet feels cold. Because if he says, oh, my feet just feels cold, well, that's different from his feet feeling numb or him having like jabbing shooting pain. Because when I hear my feet feels cold, I'm thinking, okay, that's more like a circulation problem. If I hear my feet is jabbing, electric shock pain, that sounds like a nerve issue. So then my ear's like, oh, okay, I need to pay more attention. So really getting the patient to tease out the symptoms as much as possible, I've learned is really key in neurology. So really get the patient to describe the pain. And some of the characteristics and some of the adjectives that we like to ask about in neurology is it numb? Is it tingling? Is it electric shock, stabby pain, lightning bolt, that kind of pain, throbbing, achy. And then when you then get them to characterize, then you're asking, well, how long does it last? Does it come and go? Is it intermittent? Is it constant? Because then that also helps with the differential. For aggravating symptoms, what would I want to ask about from an aggravating standpoint that would change my differential? Here's something. So if we're thinking like spinal cord stenosis, which this, if it's really in this feet, it's really not really wouldn't pay a picture of spinal cord stenosis, but position changes could make things worse, better, rule things in and out. They talk about the spinal cord stenosis like the shopping cart sign. So if someone says, oh, it feels better when I bend over, but then when I straighten up, it hurts. Am I saying that right? If they bend over in spinal cord stenosis, it makes it feel better.
Yes,
That's more indicative of spinal cord.
that's the person who's leaning over their shopping cart. You know,
Okay.
like when I push the cart at the store, I feel better. You are, because you're bent forward, and that opens up that whole area of the spine, right? Versus when you then are standing up straight, what do? You tighten all those things down again, and then the patient has more pain.
So those kind of things, or walking upstairs. Trying to think what else would be key. I'm gonna put this in shopping cart. But in this guy, particularly, things that make it worse or better. I'm not really getting any vibe that would help rule in Guillain-Barré versus rule out from an aggravating relieving standpoint. Temporal, we talked about intermittent, come and go, constant. Usually in Guillain-Barré, it's more so like just like a constant, it's there, and it tends to ascend up. So first it starts in the lower distal regions of the nerves, and it works its way up. And then other symptoms from a leg, feet, paresthesia. So here, if we're trying to rule in, rule out Guillain-Barré, things I would want to ask, you kind of got in the systemic, is any diarrhea.
Any recent illness, right?
Yeah. What else do I want to ask?
Alcohol.
Yeah, for we that we'll get into from a social history standpoint. Because then you're thinking like, could there be like a vitamin deficiency?
Nutritional.
And people that drink alcohol tend to have a lot of vitamin deficiencies. What else would we want to ask in this guy that has feet, leg from a neurology standpoint? Is there
How about any bowel or bladder symptoms?
Oh yeah, that's right. So let's see. And then since we're going to other systems, we would think respiratory, any other involvement in the hands, in the proximal muscle region. What else? Just working our way up. What else do I want to ask this guy? Walking. Is he falling? Is he having issues? So I'm looking at my feet, way up. So feet, toes. Talked about old carts. Is he falling? We talk about bowel, urinary, working our way up.
Weakness.
Yeah, weakness. General weakness or weakness in his arms or legs? think that covers it. I think those would be the key things to ask in the emergency room. Awesome. And then, so now, since we're down there, we get into past medical history. Anything really in particular? We talked about, does he have any talked about any recent illnesses, URIs, GI. For medication wise, I don't think there's anything significant that we would really want to ask. Sometimes like chemotherapy medications can cause these, paresthesias. That's the only thing I can think about, but or any medications that are known to cause, I would just take a look at the person's med list. Are there any other meds that you can think of off the top of your head that would cause like a paresthesia besides chemotherapy meds?
Medications for HIV
Oh,
can cause peripheral neuropathy.
okay. So we do meds, and allergies is always good to ask. Surgical history, nothing screaming out at me.
Yes. Gastric bypass can cause nutritional disturbance, which can cause neuropathy. Especially in people who lose weight quickly.
I see. That could be something that we ask here. Recent drastic weight loss. Fish, can't spell, sorry. Woo! Y'all, y'all are really knowing that spelling is this is why I did not become an English major. I guess here, if we're thinking like a peripheral neuropathy, does the person have diabetes or history of diabetes?
Yeah.
Then social history, we talked about alcohol use. That's pretty much the big one.
I think he put a Conti. He put something in the chat. Is that a he?
Hi.
Bill, so you're right. Is it possible to teach patients to describe their pain properly? Is it? So what I've learned is that patients are gonna tell us what they feel, and it's our job to take what they tell us and interpret it into like medical terms. So it's like we speak two different languages. We speak, the common everyday language, and then we hear that in one ear, and then when I write, I'm translating it into medical terms that help me figure out what I think is going on. So if a patient comes and tells me my leg feels funny, well, I'm not going to write that in my note because that's not going to help. That doesn't mean anything to me from a doctor's standpoint. So then my job is to tease out, well, what does that patient mean by my leg feels funny? It's like detective work. It's, well, what do you mean by funny? So it's our job to not so much teach the patient medical terms, but really help the patient help us figure out what they mean and then translate that into a medical word that makes sense to us to help us figure out our differential diagnosis. Okay, does that make sense? Awesome. And then from a family history standpoint, the only thing I pretty much would ask is, does the patient have a family history of like any nerve issues? That's pretty much all I ask. Was what I would ask in this patient. Let's see. So we talked about allergies, surgical, social. Are we missing any of the history stuff? Past medical, meds, allergies, surgical, social, family. Okay, the fun part. Now we do the exam. So key things we're going to want to do. Mental status, not really. It's not going to help me tease out my differential here, because the key for the neuro exam and the ED is like, well, I need to localize this. Patient tell me he's having paresthesia. We know our differential. So what do we need to do from a physical exam standpoint to determine to support our localization? process. So I don't care about mental status. Cranial nerves, no, not so much. Big things I would really care about is the motor exam and really testing all the different muscle groups, making sure that looking for, does he have any evidence of weakness, any atrophy, and then tone, not really. I don't really, tone is not really going to tease out our differential here, but really looking for weakness and atrophy is the things I'd be really concerned about. And then after we do motor, then I like to go to reflexes. So this is going to be key here, because if he's hyporeflexic and he has weakness in his lower extremities and the distal extremities, that's supporting, okay, this sounds like an ascending GBS, and he tells us, yeah, I had diarrhea 2 weeks ago. So this is where reflexes is extremely key. And you want to test to see, do they have present reflexes or are the reflexes absent? Or is it hyperreflexic, hyporeflexic? Because if he's having like upgoing Babinski, upgoing toes, and he's hyperreflexic, well, then in our differential, we talked about some myelopathy. So then that leads me away from GBS. And I'm like, okay, well, maybe he has some underlying myelopathy, and we need to do some spine imaging. So reflexes would be key here. So what I would be testing for is doing the Babinski, you're doing all like the basic, but also doing the Babinski. What else would I want to do? That's too much. You want to check for clonus. If we're thinking myelopathies in our differential, you want to check for ankle clonus, especially. And then after I do my DTRs, sensory, here I would be testing all the modalities. I'd be testing proprioception, vibration, pinprick, temperature. I would do as many sensory testing as I possibly could, because if you see subtleties, because what I've seen, sometimes the sensory changes happen, sometimes they happen first, and they can be your first sign of a demyelinating process before the weakness actually occurs.
How do you check the temperature? Do you do like the back of the hand or the elbow?
I do the back of the hand. I do, but you can do both, because there's like different innervations, back of hand, front, but I just do the back. As long as you're covering the lateral, middle, and then medial portion, then I think you're fine. But I always do back of the hand, because with the front of the hand, sometimes people have calluses, and that can, affect the sensory exam. I think the back of the hand is more sensitive than the front of the hand. People tend to be less sensitive in the front compared to the back. It's been my experience. So let's see. Proprioception. I think that's how you spell it. Other things, sensory coordination. I'm not really concerned for like an ataxia or like a cerebellar process. So if I'm pressed for time and I'm in the ED, I'm just going to like do high yield stuff. And doing coordination is really not going to change my differential. So I'm not interested in really doing like finger to nose, heel to shin, because he's coming in with paresthesia. So I'm not too concerned about that. Gait, I've heard gait is a really good gross exam. You can walk someone for 2 minutes and you get motor in, you get coordination, you get balance, sensory. So yeah, I would walk him and because that can kind of tell you, does he have any proprioception loss if you do like a Romberg. So if he can walk, that will determine how much weakness does he have in his legs, in his feet. So gait is very important. And then because if he has clonus and he has upgoing reflexes, and we're thinking of myelopathy, someone's gonna have the rectal exam. And let me tell you, emergency residents don't like the rectal exam. They're like, well, that's your job. You're gonna do it. So depending on if you think, well, this may not be a Guillain-Barré, but it may be a myelopathy, or we may be concerned for Cauda equina. Well, actually, Cauda equina, he would have overt weakness in his lower extremities, not so much localized paresthesia and just the feet and the toes. But let's say he came in and he had overt weakness in his lower extremities bilaterally. He can't hold his bowels. He's urinating everywhere. And he's he's paraplegic from the hip down. Then that would indicate getting a rectal exam, asking for like evidence of like, does he have like saddle anesthesia and whatnot. But if you're concerned for Guillain-Barré, I wouldn't do a rectal exam unless his symptoms were ascending to the point where it was affecting that level. So I think those are the high-yield exam findings I would do: motor, deep tendon reflexes, sensory, gait, plus or minus rectal from a GBS standpoint. So now that gets us to our workup. So we're concerned for GBS. We would have to LP this guy.
Mhm.
I always get MS and GBS confused. So MS, you have oligochondral bands. GBS, you would have albumin,
Cytologic dissociation.
Thank you. That word. And
You got it.
and which you have high level.
Cytoalbuminologic dissociation. Either way it works.
10 pounds fast, which you have a lot of protein in your CSF, but you don't have a lot of cells. Because most times when you have a lot of protein in your CSF, that corresponds to having a lot of cells, because our cells have protein in them. But in GBS, you have a lot of protein and no cells. So that's why you have that A word that Dr. Crandall mentioned earlier. Let me look. Albumino GBS. I was like, Google can read my mind. Something. I mean,
Go back.
okay, I'm gonna just click on this. Oh, this is an abstract. Actually, I'm gonna just go to, let's see, up to date. So I'm a huge fan of up to date. So I'm trying to find that word so we all see it. We all see it together.
It's albuminocytologic dissociation, right?
Albuminocytologic dissociation. Actually, I need to practice that. Albuminocytologic dissociation.
Mhm.
I put it in the chat if you want to use
thank you. Thank you. So we're looking for. So obviously, you tell them to get basic labs, CBC. I would get CMP because that will include liver function studies if you're concerned for like a GI issue. But the big thing is getting an LP and making sure that patient doesn't have any contraindications. So getting an LP. Would I image this dude? Yeah, I probably would image him. Forget like let's see, can't do MRI in the ED. Would you image him down in the emergency room? Because I want to get like a CT spine, but getting an MRI, that's inpatient, so he would warrant inpatient admission for image. Would you get imaging for
So I think your question will be is if this guy's coming in the hospital anyway, like he can't walk, he can't care for himself at home. And you're thinking this guy's going to come in, let's just plan on getting MRI in the morning or something like that. Because I don't think you need to order it from the emergency department. I don't think it's going to make a big change to your management. If you think this guy has transverse myelitis, you're going to put him on steroids. And if you gave somebody with Guillain-Barré syndrome 1 dose of steroids, they won't die. So,
Okay.
so I don't think you have to worry about that so much.
Gotcha.
If there's a history of trauma and you're thinking, well, gosh, could this guy have a spinal fracture with a retropulsed segment or something like that, then CT could be useful. But if there's no history of anything like that, I think your CT is going to be low yield.
That's a good point. You should add history of trauma.
Oops, sorry.
So I think that's pretty much the big things I would do in the emergency room. Anyone else have anything else to add? Basically, our job with this guy is really localizing. Is this a acute, hyperacute, subacute process? Really want to make sure, is it a myelopathy? If so, is it due to, what is it due to? Is it due to a stroke? Is it due to something pinching on his nerve? If not, based upon what our physical exam tells us, is it a polyradicular neuropathy? If so, is it GBS? Getting an LP, that can be done down in the emergency room. Or if not, then a lot of these other things like nutritional deficiencies, that could be worked up in the outpatient. But if he comes in and he's like, I can't walk anymore, then that would indicate this guy probably should be admitted for additional workup. Really.
Oh, MS. Again, MS also presents like paresthesia, right?
Yeah, I guess it was in the spinal cord, but typically presents as like optic neuritis.
Yeah.
Or transverse myelitis, right? Which you're going to get imaging for. So that's, what are you doing? So that's.
You put that here. Awesome. Cool. This was great.
So one of the things that I think you should always remember, and obviously this gets to be harder when you're a resident and you're busy and you're tired, right? You're post-call and people have been driving you crazy all day and stuff, is I don't have a lot of experience seeing patients who come in who kind of act histrionic and they're all over the place and 10 dozen complaints and things like that, who have bad things, right? People who have bad things are usually kind of quiet people who come in who say, well, I guess it's something and maybe I'm not swallowing very well. And how much weight have you lost? 40 pounds. You're like, well, you're really not swallowing well then, because if you're not swallowing and your weight is the same, then you're not swallowing that badly, right? I really try when people come in with a complaint that I think localizes to an area that I could say these things go together and are having trouble urinating. You scan the bladder and there's 900 cc's of urine in there. I don't know too many people who could develop a pregnant bladder that way to really have a high level of suspicion for doing imaging and making sure to rule out bad things. I saw a young gal who came in with her husband with lower extremity weakness, worse on one side than the other, and urinary retention. She had almost a liter in her bladder when she was at an outside hospital, and they CT'd her and then they sent her home and she still couldn't walk, and then came back in. And of course, by this time was well out of any kind of window to have a spinal angiogram or whatever. And now she's in a chair. I treated her like she had transverse myelitis. I imaged her. I treated her like she had myelitis. I didn't think our imaging was very good. And I gave her the benefit of the doubt, and her neuro exam was abnormal. So I think the most important thing is I did a good neurologic examination and I thought her neuro exam was abnormal. And literally the day that she went home, there was still a neurosurgery note. The surgeons were seeing her every day. They weren't going to do anything, but they saw her every day and didn't think there was anything there. And she is absolutely in a chair with an AFO on one foot. She was working as a nursing assistant and I think had a spinal cord stroke. She came in with a lot of pain and disability in that leg and urinary retention.
Wow.
And I wrote in my first note, you know, this could be a stroke, but she's young and she's female and it's more likely transverse myelitis. And I couldn't tap her because she was on Plavix. I can't remember exactly what happened. I think we took her off Plavix for a few days and then she went into AFib. And I thought, oh gosh, I wonder if this is actually a spinal cord stroke. So I do think they're getting the history and really doing a good neurologic examination. And if your exam is abnormal, then I would pursue that, you know, so you just say, the tone's increased and I think that toe is upgoing, or I think there is a subtle spinal sensory level. I think we need to pursue imaging. I think that's always reasonable.
Mm.
Yeah.
Thank you.
And sometimes, you know, you'll tap these people for Guillain-Barré. You'll be thinking this is a textbook case of Guillain-Barré, and you tap the patient and the lumbar fluid, the lumbar puncture is normal. And you think, okay, well, if I have kind of a perfect storm scenario, they were sick 3 weeks ago with an illness with, you know, upper respiratory or upper GI symptomatology, do I go away from that because the protein is not grossly elevated, or do I go ahead and just treat them and say this is early? I don't know. Yeah.
Thank you. This was phenomenal. This was fun. I know we went
It was a fun class, wasn't it? Yeah.
30 minutes past time, but thanks for staying on. And thanks for working through those 2 cases with me. I'll post this video online in the next few days, and then I'll get those notes and send it through the group chat. And just thanks. It was fun.
Thank you so much. This is really, really helpful.
And if there's any topics that anybody want you up, if you guys have suggestions or there's things you want to talk about, just let me know, and we can set it up.
Can we do TBI next time?
TBI, yeah. Do you want to do a case, or you want to talk about TBI in general?
We can do like a case and branch out to talking about it in general.
Awesome. Would you like to run like what I'm doing? Would you like to do that?
Sure. Yeah.
Cool.
I'll give it a shot and you can help me chime in.
Yeah. Cool. Awesome.
Great.
Yeah, let me know when you're free, and we could, get that on and send it, and we could do TBI.
I'm actually on a full-time job, so if you tell me your schedule, I can kind of like adjust mine.
Okay, cool. Awesome. My schedule's all over the place. But how about our next study session will be a TBI, and we can make it an emergency neurology case, traumatic brain injury, and then make that one of the cases.
Yeah. What days work for both of you?
Well, I usually play it by ear. I usually wake up in the morning and then I look at my schedule, and I'm like, oh, if I have free time in the evening, then I send out, I'll send something out. So I'm trying to think, what's tomorrow? Friday? Tomorrow could work. Friday. Yeah, tomorrow this time could work for me.
No, I have a work thing that I have to be.
Oh, okay. Then we can figure it out on the group chat.
Yeah, let's do that. Yes.
Cool. Thanks,
good.
Everybody.
All righty. Have a good evening.
You too.
Bye.
Bye-bye.